We did have an excellent first session. For the second session, we have Dr. Anita Jagannathan, who is a senior consultant and a transplant nephrologist at the Anita Hospital. Madam is from the Temple City of Tamil Nadu, Madurai. Belongs to the 1978 batch of Madurai Medical College, and she was the best outgoing student of her batch. She joined the UPSC Railway Service in 1988, and she completed her Dip and B medicine under Padma Shri Dr. KVT, our well-known physician there, KVT Thiruvengadam. She then did her super specialty Dip and B nephro at Apollo Hospital, Chennai. From another renowned nephrologist she worked under, and he is none other than Dr. Mani from 1990 to 92. She received the Young Investigator Award from the International Society of Nephrology, joined private practice very late, and her area of interest is renal transplantation and onconephrology. And she'll be talking on a very important topic which we do face very often off late for the last 3 or 4 years. We find the renal calculi even very young children, and to highlight on this we have Dr. Anita Jagannathan to talk on. Thank you, ma'am.
I'm very happy to be the second speaker so that people would have come up from the slumber, if at all any. And it was a very active session initially. I hope I will keep the momentum going on. Going on with the kidney stone disease, like what Dr. Kalidas told us, every organ, you name the organ, we tell you what kidney does to it. So no organ is spared from the kidney. And like the other person informed me that cardiac disease takes away the patient early. The nephrology community not only prolongs the life of the patient but also the relatives, and therefore Dr. Mani called his biography as Yamadharma's. I am the elder brother of Yamadharma. So he said Yama takes only life, but we take life, money and misery of patients. So the organ which many people despise or get scared, we do find it very interesting. So let's get on to kidney stone disease. Next slide, please. Okay. So to know about kidney stone disease, why should you at all know about it? Because it's an overlapping subject between the urologist and the nephrologist. So whom you should go to and what you should do. We also always have a complementary urologist with us who helps us in many ways. So to start with, kidney stone disease is around 12% of the total population. See, we know now that the populous country in the world is India. So 12% is a significant number. Among the 12%, around 50% have kidney dysfunction. So what kind of kidney dysfunction? It can be proteinuria, it can be sepsis, it can be azotemia, it can be hypertension in any form, in any and every form, or it can land up with transplant. Stone disease can be in a single kidney, it can be in a congenital kidney disease. So in many scenarios, stone forms a major role. So we see around 50% of renal dysfunction. Dysfunction doesn't mean renal failure, okay? So among chronic kidney disease, what is the percentage of people who have a history of stone or something has been done to the stone already? That's around 10%. Next is, how many people with diabetes get kidney disease? Stone disease. It's around 16% of diabetic population get kidney stone disease. And this is not astonishing, because the minute somebody has diabetes, it is not diabetic nephropathy alone. So non-diabetic disease, kidney disease, non-diabetic kidney disease in the diabetic forms around 30%. The rest is diabetic nephropathy. So you can have a stone disease in diabetes too. And then somebody did a reverse study. So they found out that suppose you get a stone in the kidney, Within 5 years, after you develop the stone, how many people turned diabetic, they wanted to know. So when you did that, it came to be around, you can see, whatever it is, 6%. So this is very important scenario for everyone. Next slide, please. Then you should know about the demography. In a demography, you should know which are the stone belts in India. So there are actually 2 stone belts. Basic reason for a stone disease is either you are a super saturator, that is, if you put a salt in the water, you go on adding salt. At one point of time, the salt crystallizes. They are super saturators. This happens because there is excess of salt when compared to water. So there are areas in India marked as red. These are called demographic stone belt of India. So there are 2 such stone belts which are identified. Now with India becoming a pan-India, people migrate. So it's very important for us to know from which place somebody is coming to. Next, the third important thing is, how did the civilization start? It started, whatever you have there, you eat. However is the climate there, you live. So these are basically diseases of the dry, arid areas where water is a very scarce commodity, or you got to go all the way to fetch water. So the stone belt is this. Next slide, please. Then age group. Do you get stones in children? Yes, we do. When you get stone in children, you think of 4 diseases. That is when a child grows up. We don't see neonatology, and pediatric nephrology is a separate issue. But when the children come to us after the age of 12, what are the diseases you think of? You think of a dental disease, which is again autosomal recessive disorder, where you get kidney stones. Then you see oculocerebrospinal diseases. The third one you see is Barter's syndrome. A Barter's syndrome and renal tubular acidosis, distal renal tubular acidosis. These 2 disorders are basically tubular disorders, where the defect is in the defective absorption and secretion of electrolytes. So these people present again with stones. But the major differences between both is people with tubular disorders develop polyuria instead of oliguria. They don't develop hypertension, they develop nocturia. Because if they have polyuria, they have nocturia. And they don't develop edema, they are without edema. And then the third thing is they develop a lot of bone disease because a lot of calcium is passing through the urine. So this is how tubular diseases are identified. Tubular diseases are identified not saying, oh, I'm okay, my urine output is okay. No, if you pass in excess also, you do have a renal disease. So you should remember, those are all tubular disorders. A child doesn't grow tall. You just ask the family history and tell them, all your people are tall, but only this boy has not grown. Probably has got a renal tubular acidosis. So people with renal tubular acidosis don't grow very tall when compared with the rest of the siblings. Next one, what you got to find out from the patient is a careful history of periodic paralysis. Some people have some potassium hypokalemic periodic paralysis you don't look into very carefully. So those people can also have a stone with distal tubular, renal tubular acidosis. These are the common features in a child having a stone disease. Then coming to the adult population. In this, men have more stone disease than women. Why? Because the bony skeleton is more stronger in a men, and their 24 hours urine calcium is a little higher when compared to females. But it is not true always. When you attain menopause, when you have a little osteoporosis, what happens is even calcium levels remain normal in both. But the amount of urinary loss in the calcium is little higher in women as they reach menopause. So during that period, the stone disease is more common in women. So, and then the fourth important clue. Suppose a young lady develops a stone disease. What do you think of? You think of primary hyperparathyroidism. So whenever a young female comes with a stone disease, the bell should ring in your brain that it can be a primary hyperparathyroidism. Next slide, please. So next, As all you all know, obesity. Obesity is a major risk factor for stone disease too. So why? Because obese people, they are not very active. They don't sweat a lot, and then they don't drink water also a lot. So that is one reason. Next is many people who are obese nowadays don't want to be obese. The easier way is to go to surgery. So many people land up with bariatric surgeries. So when you do a bariatric surgery, you either do a resection or partial resection of the stomach, or you do a Roux-en-Y anastomosis. When you do this, what happens? The amount of calcium absorption from the gut is reduced. Calcium and oxalate compete in the same transport for stone disease. So after some years, you can see a bariatric patient coming with a renal stone disease and oxalate stone. So that's why they have now revised their technique, doing more and more of Roux-en-Y than sleeve gastrectomy. Next is patients with metabolic syndromes. Many metabolic syndromes can, your common metabolic syndromes with obesity, diabetes, all these can produce renal stone disease. Fourth one is diabetes, as I told you earlier. Next slide, please. So, therefore, a careful history is very important. After the history comes diagnosis. Actually, this slide has been put up by my daughter. She's a chartered accountant, so she helped me doing the slide at the last minute. So she skipped the slide. Okay. So diagnosis is very important in the sense we got to take a proper history from a patient, whether he is a first-time stone patient or whether he is a recurrent stone former. Because the basic way which we look into patients for a stone disease is very different. If you have a recurrent stone former, we have separate investigations to be done. We got to see periodic follow-up. If he is a first stone former, we tell him, see, this is the first time you have developed stone. You have 90% chance of recurrence of the stone in the first year. And for 5 years, 50% chances are there. So we got to first tell the patient and say that you need a periodic follow-up. If he is a recurrent stone former, then we got to do it in a different way. The third history which we need to take is a history of gout. Any patient with a history of gout, you got to ask whether he has any history of joint pains and all that. So next comes your diagnosis. So how do you diagnose? Earlier days we used to have X-ray and then we used to take an ultrasound. But ultrasound is not very specific, not very sensitive as far as stone disease is concerned. Do they play a role? Yes, they do play a role. Where? When you want to look in for a recurrent stone formation, or when you are looking at a patient in a special situation. Suppose your patient is pregnant, you just can't ask them to go and get a CT done. Because the difference between an X-ray and a CT is 1,000 times more radiation with a CT than with an X-ray. We just cannot take off X-ray like that. But we have just come out of an X-ray for the accurate diagnosis as far as stone disease is concerned. Again, for a periodic follow-up, you can as well take an X-ray KUB and see whether somebody is developing a stone. Need not expose them so many times for irradiation. So, X-rays do play, but not that much a role. There are certain stones which are radiolucent. They are xanthine stones, cystine stones and all that. Uric acid stones. All these stones are not radio-opaque. Just because an X-ray KUB is normal, you cannot say somebody has got a no stone disease. So ultrasound, what is the problem with the ultrasound? Ultrasound is good enough, but what happens? We can't see the ureters. We can't see the ureters, and then we should see the stone with the after shadowing. So many a times it will be difficult in an obese patient to look at the stone in an ultrasound. So then, but if you do a CT, you can look at many things, and therefore we do require a good helical non-contrast CT for a good estimation of stone disease. So does ultrasound play a role? Yes, it does play a role in special situations. You cannot go and do a CT exposure in a transplant patient and in a patient who is pregnant. Therefore, you do require an ultrasound, not that you can throw it off. But when you compare, the non-contrast CT has got specificity and sensitivity. See the sensitivity and specificity. 95%, 96%. Very, very useful. Not only that, we got to look at 5 things on the CT. What all things you see a HFU unit. So you got to go back and talk to your radiologist and ask him. Many people don't write it. So when it is a low HFU unit, then it's a uric acid stone. If it is a high FCU unit, then it is a calcium stone. Then second thing is you can look at the skin to the stone distance. This is very important because the distance is more when you do a ESWL or when you try to hit a stone with an extracorporeal therapy. It's going to be difficult. With one sitting, you will not get the stone out. Then patients will complain, hey, you sent me to an ESWL, the stone is not coming out. Stone won't come out. If you are obese, the sound waves have to travel such a distance for it to get hit properly. So we got to look at the skin and the stone distance. Third is collecting system abnormality. You cannot go and hit a stone without knowing what's happening down. You can have a duplicated system. You can have a horseshoe kidney. You can have a single functioning kidney. To see all that, you require a CT. Okay? And then delayed nephrogram picture. This is very, very important. Suppose a patient with a stone disease comes with fever. So you got to see whether there is any reduction in perfusion in that particular kidney. So if somebody has got reduced perfusion in one kidney, nothing happens. The other kidney is there, renal functions will be normal. But only thing is, if you develop sepsis on top of it, you will get into acute kidney injury. So therefore, it is very important to look at the delayed nephrogram picture. The fifth one is the gas and the perinephric stranding. This is for associated pyelonephritis. When the stone is in the kidney or in the ureter, you got to find out whether the patient has got pyelonephritis, and it has to be a combined effort with antibiotics and, if required, surgery on an immediate basis. So therefore, all these details, many ultrasonologists do not give us. It's our responsibility to go back and tell them, see, we require all these. So many a times I see a picture with a plain CT, one cut here and one cut down, that's it. And then if you tell them again, oh, the CT is not good looking, he looks at me and says, you want money. The way patients look at you, you know. You say, why are you asking for one more? So these are not there. Kindly go back to the radiologist and ask him to do it properly. Then you get a bang from the radiologist too. Next slide, please. So next, common stones in adult population. What are the common stones? Common stones are calcium stones, uric acid stone, and the rest is a cystine stone. So calcium stones you all know. It is a radio-opaque stone and it's very common. Next to the uric acid stone. Uric acid scenario is very different. You can have it because of enzyme defect. You can have it because of malignancy. You can have it because of many reasons. So when somebody has a uric acid stone, you should be very careful to rule out other comorbid features like diabetes, malignancy and all that. The third one is a cystine stone. Cystine stone story is very interesting. Once we all bumped into a patient who had a transplant, who never gave a history of stone disease at all. And the mother is absolutely class 1 donor. She gave the kidney. Within months or so, he came back. He is from Viluppuram. So when he came back, he saw his kidney studded with stones. We have never seen a patient like this. So then slowly we asked the history, where is your father? My father is no more. Where is he when? He has left us and gone away. Do you have a brother? No, I have a brother. Please get him. So we looked at his brother, absolutely normal. And then we have looked at the donor also. So then we didn't know what to do. And then luckily for our good fortune, he passed a stone. And then we saw the stone was very different from the rest of it. So we thought we will send it for analysis. When we sent to this lab, they said, we have never seen a stone like this. So kindly keep the specimen carefully and then we'll send it to Bombay. Then immediately I got a call from Bombay, SRL lab saying that Oh, this is a stage stone. So which is less than 1%. But the problem is, we took a proper history, we did everything. Because it's an autosomal X-linked recessive disease, incomplete forms are all very common. So we try to tell them that incomplete forms are very common. So this is how you got it. So you're not supposed to go for a liver transplant. You got to go somewhere else, outside. So we got to get a special permission from the authorization committee. So we had to go all around back again to get another transplant done for the boy. So this is the story of a cystine stone. So never forget. Sometimes an abnormal stone, which is very rare, but one patient costs you so much trouble. Next slide, please. So investigations for the test. You do a urine examination. In the urine examination, we got to look at for pustules, because the second, third most commonest cause of urinary infection in a patient is stone disease other than the prostate. So we got to look at it carefully. The next cause, second cause is people treating urinary infection for a very short period of time. Because unlike there are certain places where you require prolonged antibiotics, especially pyelonephritis, endocarditis, prostatitis, all those places, vascularity in few places is more. So you require for a longer duration. Many people use it for a very short period of time. So repeated urosepsis is common. Second cause of repeated urosepsis is stone. Third one is prostate. So therefore in a urine examination, just don't look at the pH only. Look at the urine carefully and look at for urinary infection too. Next is, you got to look at your phosphorus and calcium levels in the blood. Then you got to do a urine culture to rule out any infection. You got to look at the renal function. You got to tell them you may land up with pyelonephritis and acute kidney injury. So you got to be careful about that. Then you got to look at your uric acid and serum calcium and phosphorus. Then 24 hours urine calcium is very important. Three magical numbers as far as urinary stones are: 24 hours urine calcium, 24 hours urine uric acid, and 24 hours urine oxalate. So again, all these numbers: 200 milligrams for calcium, 40 milligrams for oxalate, and 600 milligrams for uric acid. pH is very, very important because uric acid stone form in an acidic media. Calcium stones form in an alkaline media. So if we try to alkalize the stone with a patient with uric acid, you develop a calcium stone and come back. If you overtreat a patient with a calcium stone with all the time giving bicarbonate, you will end up with a uric acid and come back to you. So it's a double-edged sword. We have to be very careful and tell them. So next slide, please. So why do you require an arterial blood gas? You require an arterial blood gas to rule out any renal tubular acidosis. And so acidosis, metabolic acidosis. What we normally do at the lab, the bicarb, is a measured bicarb. It is not the actual bicarb. So if you want to look at an actual bicarb or incomplete forms of renal tubular acidosis, you do require an arterial blood gas to find them. Next is, you do a DEXA scan. I told you, you do a DTPA renal scan. Why do you require a DTPA renal scan for a patient with the stone disease? You got to look at the renal measured GFR. So you got to look at a measured GFR. These are all for patients who come repeatedly with stone disease. Not for everybody you do all these. Then you require a DMSA renal scan for any scarring. Stones can produce scars. Okay, stones can get impregnated inside the renal parenchyma or in the collecting system and get stuck. So when it does that, it forms a scar. So how to identify a scar? The scar is really painful as the stone. So many patients will come back saying that I have got pain, I have got pain. The renal scarring produces pain. You've got to explain it to the patient. So therefore you require a DTPA renal scan too. Next slide please. So third one is special situations in stone disease. So what do you do in a decreased renal function? You got to always take the help of a nephrologist along with the urologist. Second is in a single functioning kidney. Very, very careful when you tell them. So many people have to either put a DJ stent. Many of the doctors and many of the patients forget that there is a stent. They go on with the stent for times. immemorial, and then they come back when the stone is when the stent is broken. So you should never have a stent for more than 2 months, 6 weeks max. But many people, around 60% of them with the DJ stent will develop infection within 3 weeks. So always make a note that somebody has a DJ stent, always. Next, post-transplant scenario. Very important, when you should ever do a transplant in a patient with stone disease. So there are 2 important conditions. One is when a patient has got acystinuria. Next, patient with a hyperoxaluria. This is called primary hyperoxaluria. Primary hyperoxaluria is a disease where the enzyme is deficient in the liver. So what happens? Patients form lots of oxalate crystals. The amount of oxalate crystals they form is such phenomenal that when you do a transplant and then when you remove the renal artery, the entire kidney will be studded with oxalate crystals. So I have seen 2-3 patients in Vellore when I was working, developing primary oxaluria right on the operation table. So what are you supposed to do? You got to take a proper history of whether patient had a stone disease or not. So initially we were doing lots of plasma pheresis, trying to remove the plasma as quickly as possible and do the renal transplant. Now we do both combined liver and renal transplant for all patients with hyperoxaluria, and they all go on very well. So that is very important to know when you should not do it. Okay, and then stone and pregnancy. Very important in stone and pregnancy, how you should go up. Next is stone and urosepsis. Very interesting. So when somebody develops a urinary infection, normally it's E. coli. So when you get abnormal organisms like Klebsiella or something else, Proteus growing. So why should somebody develop Proteus, Staphylococcus, Klebsiella growing? So then you always think that there is a stone disease. Because all these organisms produce something called urease. These organisms produce urease and the ammonia is acted upon by the urease and then it is converted into bicarb. So they form a very alkaline pH and they all develop repeated stone disease. So microorganisms are very important as far as stone disease is concerned. Third one is very difficult to treat Klebsiella and Proteus species in kidney disease. So they are not very antibiotic friendly. And then the amount of Klebsiella resistance we get nowadays is absolutely mind blowing. So it's very difficult to treat a Klebsiella pyelonephritis with a stone disease. So we got to have it in mind. So the microorganisms are not always very unfriendly to us. There is a friendly microorganism called the oxalobacter. So what does oxalobacter do? It prevents the crystal formation of oxalate. So now they have come up with a tablet called oxalobacter for patients who have got primary hyperoxaluria or secondary hyperoxaluria. You give them for 3 weeks. What it does, it doesn't make the stone disappear. It only makes the stone grow slowly. So that they have recently gotten. So antibiotics are not always unfriendly, they are friendly too sometimes. So now we come on to the special situation of stone in pregnancy. You all know 4.7% of people out of 1,000 they develop stone disease. So hyperemesis in the first trimester produce lot of vomiting, dehydration. Anywhere any dehydration is there, the stone will supersaturate. The stone will become much more prominent. So next is your stone growth increases. Third is physiological hydronephrosis. So normally in a pregnant woman there is a physiological hydronephrosis. So you won't know whether this hydronephrosis is because of stone or it's a physiological one. It's very difficult to find out. Next is ultrasound. Only modality where ultrasound is most useful is during the pregnancy. But to our, so you cannot use CT. So CT is contraindicated because the radiation is very, very high. But people are nowadays using what is called a low dose CT, which has been used widely in the West, but I am not very comfortable with it. Next is many of them passed, 87% passed their stone by themselves. So very happy. So we got to manage only the rest 10%. Next is ESWL, cannot be used in a patient who is pregnant. So you got to use put a stent or do a ureteroscope slowly and then manage patients with stone disease in pregnancy. It's quite challenging that you got to combine with a gynecologist and urologist and have a combined modality to remove the stone. Then symptoms in kidney stone disease. Nowadays many are asymptomatic. They go and do an ultrasound for something, they find a stone there. So that is very common. Next, if it is a very small stone, you can just leave the stone. So 90% of the stone which are less than 5 millimeters, they just pass the stone by themselves. You are only hyper unless it is blocking somewhere. The second one is any stone which is more than 5 millimeters, you got to be very, very careful. You got to tell them you might pass the stone. You might not pass the stone if it is more than 5. So 5 is the cutoff factor. Many people use 7. I use 5 because when you look at the ureter, the ureter is not a rigid tube. The ureter is just flexible. So in 3 places the ureter is very tight. One is the pelvic-ureteric junction, next is the mid-ureteric place, and the third one is the place where it joins the bladder. Now all these 3 places, it is little narrower. So what happens? It just doesn't fall like that because of gravity. So those places will get stuck. So when it gets stuck in those places, it's very difficult for the stone to come. Next is you can wait for a period of 3 weeks. So if the stone doesn't come within 3 weeks, you got to manage. So these are the criteria normally used. So why does the stone produce a renal colic? All stones produce renal colic? No. There are people with the staghorn calculus happily living. If you take an ultrasound, the staghorn calculus will be there, cortex thinned out. Cortex contains glomeruli. The medulla is only the collecting system. So all the glomeruli is gone. Only staghorn calculus is living there. So you don't, unless it is infected, you don't go and meddle with the kidney. So, but that is a source of infection. Suppose you want to go for a transplant. You just cannot go and do the transplant here and look at that staghorn calculus there. So what you should do a removal, see that it is not infected, see that the bacteria is not sitting there, fungus is not sitting there. You got to do so many things. You got to plan a pre-transplant nephrectomy and then go for a transplant later. So this is very, very important as far as staghorn calculus is concerned. So when does a stone produce pain? Stone produces pain only in 2 situations. The smaller the stone, it produces pain more. The way it is moving, it produces more and more pain. So the next is infected, it produces pain. So otherwise stone disease never produces pain. So you should be very careful in managing a renal colic. So how do you manage renal colic? Normally you give a centrally acting narcotic agent along with a little anti-emetic agent. So normally we use that. And for the ureteric muscle which is there, we also use an alpha-2 blocker. What you use for a prostate, we use tamsulosin, or people have used calcium channel blockers too. So they have used nifedipine in small doses for the stone to be pushed out. But these we can try only for 1 or 2 weeks or 3 weeks. The stone is getting stuck there, better send them to the urologist. Third one is when you get fever, you should be very, very careful. You should do a urine culture, blood culture, and then you should see in a diabetic patient fungus, especially mucormycosis, very common after COVID. We saw lots of patients with mucormycosis and aspergillus in the kidney. And so never forget fungus. It might cost patient's life. Flank pain. Many people will get a flank pain. The flank pain is very typical, and then I will not explain more about it. Many people are asymptomatic. So next slide please, treatment. So what do you do? Dietary management. What do you do for a diet in a patient with kidney disease? First and foremost thing is you should tell them to take plenty of water. How plenty is plenty? Depends upon how much you sweat, what amount of work you do. But the insensible water loss is around 500 ml. So if somebody is passing urine, every person's urine output is not the same. So every person passes different urine output. So ask him to measure the urine and at least take a liter of water more. So if you take more and more of water, what happens? Water and sodium are made for each other in the kidney. So what happens? There is a low sodium. So when there is a low sodium, calcium absorption is lower. So the calcium will come out through the urine. So that is very important as far as diet is concerned. Calcium. So people have got this tendency, oh, you have calcium stone. Oh, stop taking all calcium. So when you stop taking all calcium, what happens is, I told you earlier, in the gastrointestinal tract, the absorption of calcium and oxalate are through the same transporter. So it should never be on a low calcium diet. So if somebody is very finicky about it, tell them please go to the dietitian and prescribe a diet for 1000 to 1200 milligrams of calcium per day. Don't say low calcium. Low calcium will always increase oxalate stones. So that we should remember. Next is uric acid stone. Uric acid stone always forms in a dehydrated patient. So hydrate the patient enough. So next is acidic urine. You alkalize their urine, because in acidic urine, uric acid stone grows. So the third thing in a patient is the malignancy. They also use allopurinol and febustatin. The difference between allopurinol and febustatin, both are good enough. But allopurinol has got little more side effects in the form of rashes, Stevens-Johnson syndrome and all that. Whereas our febustatin doesn't have all that. And then they compared a head-on trial with allopurinol and febustatin. When they used it, they saw recurrence rate was only 5%, but side effects were very less. But febustatin, for a period of 6-7 years, they never saw any recurrence. So nowadays they use febustatin. So I am also interested in onconephrology. So I go over to cancer hospital. When I go there, I see them not using either allopurinol or febustatin. They use something called rasparegates, which is urokinase. What it does, it just breaks down the uric acid which is formed in the kidney. So their uric acid level in a tumor lysis syndrome is somewhere 15, 16, 17. So they cannot be waiting. And mind you, all uricosuric agents does not prevent gout. For gout, you require another medication called colchicine. Many a times when you do this, gout will come up. So you should be very careful and tell the patient, you may develop gout also, please be careful. And then people cannot say, come and say, hey, I have taken medicine for uric acid, I am developing gout. Both are entirely different. So you should be very much aware that gout can come in a patient who is taking a uricosuric agent. Then avoid animal protein. Why should you avoid animal protein? All animal protein makes the urine acidic. Therefore, you avoid acidic stones will grow faster. So therefore, you avoid animal protein. And animal protein also supposed to damage glomerular filtration by a hyperfiltration hypothesis, which was suggested by Brenner. So he was about to get his award for that is called hyperfiltration hypothesis. When you take a lot of animal protein, the glomerulus becomes big. It tries to hyperfiltrate. So when somebody is going on trying to hyperfiltrate, it fails. So that's how you are supposed to avoid excess of animal proteins. This basically, and therefore you got to take protein appropriately, not fully stop animal protein. The second reason why you should never take first class animal protein in plenty is formation of uric acid again. The red meat contains good amount of uric acid even in a single diet. So that's very important. Next is high sodium diet. Precipitate stone. I told you stone. Therefore you take a low sodium because the urine will be flushed out of this calcium. Next is you take a high potassium diet. High potassium diet again flushes out the calcium absorption, therefore you can take a high potassium diet. Again, this potassium and sodium are on the opposite side. When you make it one low, the other you can make it again high. So the third one is high magnesium diet. High magnesium diet also is very important in stone disease. So urine pH, you know, I already explained it to you, how you got to go about urine stones and pH. So next slide please. So drugs and stone, can drugs produce stones? Yes, they can. What is the percentage? Around 1 to 2% of stones are because of drugs. So these are the drugs for HIV. Many are protease inhibitors. Many of them except tenofovir. Rest of them have got a tendency to produce little stones. And then somebody has written a mistake, xanthine. Xanthine is used in some coloring dyes and all that. So colored foods. So xanthine is converted into uric acid. So you're not supposed to take all different color blue, blue colored drink and very orange colored fruit juices and all that. It contains synthetic xanthines. Then comes cefuroxime. It's a very interesting study recently done in children. So they were giving lots of cefuroxime for children for more than 7 days in many hospitals. They all found out that many people develop stones. So they are yet to explain how, but this is the study which is recently published, which is an examination question for the nephrology board. So every year we take a nephrology board exam. So this is a very important question for that. The next is topiramate. This is an anti-seizure drug. So this is available in India and many refractory seizures, the neurologists use it. I came across one patient who had a stone disease following that, and they also developed nephrogenic diabetes insipidus with low sodium. So we stopped both and patient became better and converted it to another seizure drug. So next is this orthirostat is a drug which is used for gastric lipase inhibitor for obesity. I told you obesity has got a lot of connections with stone disease. So this is one. This drug inhibits the gastric lipase. When it inhibits the gastric lipase, what happens? Fat absorption is less. When the fat absorption is less, calcium is absorbed less because vitamin D is necessary for calcium absorption. So third, finally is many herbal medications, as I told you. We do not know, but we got to find out and do whatever is necessary. So surgery and stones, okay. Surgery and stones is a very big topic which I don't want to touch more. But intestinal resections again can produce lot of oxalate stones, sleeve gastrectomies, bariatric surgeries. I told you already about microorganisms and stones. Next slide please. So treatment of stones, calcium stones, what do you do? For any stone, you ask them to take plenty of water. How plenty is plenty? You measure the urine output, calculate your sweat loss. Normally, if you sweat profusely, you will lose about 500 ml. So you got to tell them to add 500 ml, but for a summary day, you add more. So take enough fluids and then give thiazide. Don't do reverse. Why do you give thiazide? Because thiazide acts at the early distal convoluted tubule, where calcium is absorbed with the help of parathyroid hormone and vitamin D. So when you do this, your calcium absorption is lower and you push the calcium out and therefore your calcium stones are formed less. How do you, best way is to analyze the stone first. Tell all the stone formers to collect your stone. How do you collect stone? Whenever you are getting a renal colic, pass through the tree strainer. When you pass through a tree strainer, collect the stone and get it for us. Like how you put different kinds of stone in the ears, there are different kinds of stone. All stones are not the same. Please tell the patient that first. And then you give a thiazide diuretic. There are about 12 multivariate trials which have been done, which all said that if you give enough fluid and then give thiazide, it really works. So you give a small dose of 12.5 milligrams. This is called therapeutic paradox, where you give plenty of fluid and then give a diuretic too. So this is another question which is basically asked in the exam. So where do you use thiazide as a therapeutic paradox? We use thiazide as a therapeutic paradox in a patient with central diabetes insipidus. What happens when you do it? When you give a thiazide, it acts at the distal tubule. So the intracirculatory blood volume will become less. So patient will pass less urine. So that is again very important. Thiazide is very important, but you got to be very careful when you use it. Next is what do you do for all these true-white stones and all? They don't come out just like that. They are stag horn calculus. The stag is like in the form of a deer's horn. So they don't come out like that. You got to use multiple combined therapies for true-white stones. Then what do you do for hyperoxaluria? You use lot of pyridoxine. Pyridoxine is very cheaply available. You use in the dose of 25 to 1000 milligrams per day. But nowadays, even that, the oxalate amount of oxalates people secrete is really high. I don't know, probably you got to analyze many food materials which contain plenty of oxalate. So you should avoid all that. Next is you got to do a liver and a kidney transplant for hyperoxaluria. For uric acid stone, I told you, allopurinol, febustat works. For cystine stones, when most difficult to treat cystine stones. And finally, it so happened that all of us collected all cystine patients together. in Madras chapter of nephrology, and it pooled. And then we have at least a family of cystine stones now, because it's very difficult to treat. And then you get all these drugs, penicillamine, toprovin, captopril, but very bad prognosis for cystine stones patients. Okay, and then for stomach stone, I told you surgery is required. Next slide, please. Thank you very much.
Any questions?
They said that chocolate, black tea and all.
Yes, black tea contains lots of oxalates. So many things which are very fashionable. Especially, I've seen people who are taking. I know, and I'm sure all of you will know one of the big gynecologists was in the habit of taking around 100 teas per day from Sri Lanka, from Kerala. So found a lot of oxalate stones in it, especially green tea, because it contains good amount of only oxalate. And lots of people drink plenty of grape juices. It also contains plenty of oxalate.
The apple cider vinegar dissolves in stones.
Dissolves. So anything in excess is harmful. As far as stool is concerned, and pH, monitoring pH and treating patients is very difficult, because these are all continuously it's a continuing, it is not equilibrium. Every minute everything changes. So it's very difficult to come to a conclusion and very easy to talk, but very difficult to manage. That all of us should know. That's why recurrences are more common. Because pH is something which is dynamic, it's not static. Urine pH is not static, depends on so many factors. So when there are so many variables, it becomes very difficult to treat and recurrence rate is low.
Is it a myth that tomato?
Very much a myth. Tomato has got no connections. At least the Vadakandu has got a lot of fibers.
It stands to meaning.
Little stands to meaning, but doesn't make wonders. But tomato is absolute myth.
Okay.
Madam, you were telling about centrally acting painkillers. You mean the Dotatin?
We use tramadol. We use morphine, pethidine, depending on patients. We don't use them on a very old patient. We don't use them on a patient who is already dehydrated with fever and all that. So we just manage like that. But in a young patient who is splitting up with what severe pain, we do give narcotic analgesic. But there is nowhere mentioned in any book to give plenty of IV fluids. Initially they used to have an idea. If you get a stone, you give 6 liters of IV fluids to flush it. That's called flushing therapy. There's nothing like that.
A lot of prescriptions says the prescribing cystone has got any effect, madam?
Oh no, nothing. No, tons and tons of cystone makes Himalayan company richer and richer, according to us.
But we do get a lot of patients using, especially in Kerala and all, Ayurvedic medicines, stones and nerves. Some studies they do tell that there's some benefit.
Yes.
I don't know anybody. See, 90% of the stone pass by themselves. Only 10% we are bothered. So anything can happen. I can blame Ayurveda, he can blame allopathy. So it's not a
Stone
variation.
seems to be having some preventive thing, not therapeutic, but some preventive studies are there.
It's a herbal drug.
Okay, there's no question.
Regarding tea, is there any difference between milk tea?
Yeah, there is a difference between milk tea and green tea. Green tea is a concentrate of tea. Tea contains a lot of oxalate.
And
So which is little lesser risk?
As far as stone is concerned, milky tea is little better than green tea.
Any combinations, or that many people say that you take protein, you avoid the tea, something in combination. So is it like that?
No, nothing to my knowledge.
What about mushrooms, madam? Uric acid.
Uric acids are high in mushrooms, definitely. If you want diet and stone disease, we have got at least 3 different charts. I can project you next time when I come. So what are you should not take in excess actually. And sesame seeds and lots of these eggplant, nuts
and things.
and all that. Those are all basically from, see, all these dry nuts, dry fruits are basically from places where it is dry.
But flax seeds, they say superfood, sir. Flax seeds.
We got to look into it and then let you know. Diets and stone itself is a very big topic.
Okay, there's no question. I think we can wind up today. Thank you, madam, for the lucid presentation.